Welcome back, Richard. It's good to see you once again this morning already.
Good to see you. Yep.
I really am liking the two podcasts a week thing. We started it last week, and here we are with us 2 weeks in a row.
Yeah, it's like writing when you're a college teacher. I mean, you and I both have had that experience. And you say, well, why do you do research and why do you write? Because it's a way to inform yourself. And the same with these podcasts is that it's a good way for us to stay current, to talk about issues of interest and keep ourselves informed.
Right.
And one of the things we're going to talk about today is, speaking of keeping you informed,
Right.
is another, and I use quotes here, another diagnosis. And this follows last week's podcast, wherein we discussed something called pathological avoidance disorder, which essentially is your child or your partner telling you, no, I'm not going to do that. I'm too, it makes me anxious, and I'm so anxious that I simply can't do it, and I'll do everything I can to avoid it. And what we learned last week, that is particularly relevant when you're talking about individuals who have autism, is that they will fight mightily to do what they want to do and to avoid what they don't want to do.
Right.
But it's not a diagnosis. And what our fear is that people will accidentally or unintentionally assign the diagnosis to their children when they really shouldn't be considering their child's avoidant behavior as a pathological condition.
Right.
So we have another one of those things that's creeping into the nomenclature. It's creeping into our practice.
Right.
And it's rejection sensitive dysphoria.
Right. Yeah. And it's so interesting because after we did the last week's podcast, and pathological avoidance disorder is also referred to as pathological demand avoidance, PDA.
Right.
But they're kind of the same thing and just a slightly different name. But I ended up having a new patient where the parents came in and referred to him as having pathological demand avoidance. And it's fascinating how it has permeated into the general population, I guess we could say, because as you said, that's something that's really been talked about within the context of autism spectrum disorder, but now it's getting out everywhere else. And this new one that we're going to talk about today, the rejection sensitivity dysphoria, is similar. It's been talked about in certain contexts, but now here it is leaking out into just common nomenclature. People are just talking about it as just like anything else.
Right. Yeah, they have a tendency to leak out from where they were first used. Researchers or specialists or clinicians will assign a label to something, pathological demand avoidance, and it's appropriate in that very narrow context.
Right.
But these terms have a way of leaking out into more general parlance, more general speech. And that's what we fear with whether it's PDA or this RSD, rejection sensitivity dysphoria, that it tends to leak out. And with the availability of this information through the internet, there was a time when, unless you had access to medical journals, you wouldn't be aware of these things. Well, now with the internet, people could just simply go online. Now we have AI, and AI will give you these things. It'll just produce this stuff as part of the discussion. And so that facilitates this leakage into common parlance.
Absolutely.
So today we want to talk about this second quote diagnosis of rejection sensitivity dysphoria.
Right. And this is a condition, as the name suggests, and where a person feels really intense, usually exaggerated, much more than what would be expected, emotional pain related to some form of rejection. Now, when we're talking about rejection, our experience really with people who've talked about this is that rejection is also very broadly defined. So rejection could be anything from, being rejected in a relationship to rejection where you say, hey, mom, can I get that Lego set? And mom says no. And then there's a big reaction to that. So again, those of you who are listening may be, tilting your head and wondering, wait, what? Yes, it ranges in anything from what would be considered a pretty serious, important rejection that we might experience in life to the relatively benign, minor rejection of you can't buy something that you want, or something that you submit for an assignment for a teacher or something like that is rejected or graded poorly. It could be anything,
Right.
any form of rejection.
Right. And so that's a good place to start, because you're talking about all kinds of rejection.
Right.
We tend to think of personal rejection, like, I want to be your friend. Like little kids, I want to be your friend. No, we don't want you to be in our group, and you get rejected. Or there's a birthday party and you don't get invited.
Right.
It's rejection. The other part of this that's important is the dysphoria, the word dysphoria. And that's also very troublesome to me, because dysphoria means a very strong or overwhelming feeling of pain or discomfort. What is overwhelming? Well, what's overwhelming for me might be manageable, but for somebody else, it might cause them to withdraw into their bedroom and never come out again. Okay.
Right.
So we have to be very careful with this word dysphoria. And we're talking about a significant and overwhelming feeling of pain or discomfort that could impair other life functions, other life interests or endeavors.
Right. And I think what's important, the other important piece to this is, it's rejection sensitivity dysphoria. It's not rejection sensitivity disorder. And so this is a
Right.
phrase, this is a presentation that sometimes clinicians or researchers will talk about as sort of symptomology. It is, it has been connected in many ways to conditions like attention deficit hyperactivity disorder, ADHD.
Right.
Sometimes people will talk about it in relation to disruptive mood dysregulation disorder. It's a type of mood disorder or depressive disorder. And they'll talk about it, therapists or researchers may talk about it as sort of a part of the symptom cluster that the person is experiencing, that, hey, they have rejection sensitivity disorder. So suggesting that, they have a hyperreaction, an overreaction, over response to any type of rejection. They're not talking about it as a separate condition, as a separate, disorder or anything like that. They're talking about it within the confines of a particular disorder as part of the symptom presentation.
Right.
But again, I think that what seems to be happening, like with PDA, is that people are taking it outside of that context and sort of leaving it as a standalone idea. And that's not really the way that it's been intended to be used.
That's right. Yeah, it was originally meant to be embedded in a recognized diagnosis like ADHD or DMDD. But again, there's this tendency when we use the term for it to percolate out. Or if you can imagine a teenager looking for trying to understand their feelings, these very big feelings that you have when you're a teenager or a young adult. They're searching for answers, and they stumble on this. Oh, this is, I'm in my college dormitory room, but I never get invited to go out with the group. And so there's this rejection, and this explains it. I have rejection sensitive dysphoria. It's not a diagnosis, and that's why we have to be very, very careful. But It's
Right.
going to leak into it's going to leak into our practice, and
Right.
people are going to ask about it.
Now, so we have to think about, you know, no one likes being rejected, right? So there is, we all have some level of rejection sensitivity. We don't like it, and some people respond more to it, some other people respond less to it, but we all have some rejection sensitivity. And it's possible that that rejection sensitivity is different than RSD, what we're talking about that's associated with some of these mental health conditions like ADHD or DMDD. What we're actually talking about is emotional regulation, right? We're talking about our ability to regulate and control and manage our emotional reactions to things that are happening around us or things that are happening to us. And so
Right.
when we see that we've been rejected or we have a perception of being rejected, how do we respond and manage those emotions? And when people are emotionally dysregulated, they can't handle those emotions very well, then they're going to have an overreaction to that rejection.
Right.
Now, what tends to happen is they tend to have a hyperreaction to lots of other things, not just rejection, but because they find this on the internet or something like that, they're going to attach that emotional dysregulation to RSD, whether it should be or not. So we need to talk about what emotional regulation is.
That's right. Because what we constantly remind individuals of is that you need to be able to control your emotions and not have your emotions control you.
Right.
You're right. Rejection is a horribly emotional, painful experience. I mean, most of us have experienced it at one time or another, either with our children or partners or parents or siblings or somebody. We feel that rejection. Yeah, that's a painful experience, but you have to be able to manage that pain. It doesn't matter what the source of it is, whether it's grief or loss or rejection. You have to be able to manage those emotions. And when the emotions take over, when the emotions gain control, then that's a place that you want to avoid, and that's what you don't want to have happen. And I think with this non-diagnosis of rejection, sensitivity, dysphoria, I think the message here is your emotions now, that's the dysphoria part, your emotions now have taken over, and you're no longer able to regulate them.
Right. So emotional regulation is by and large brain based, right? It is part of our frontal lobe system that helps to regulate the way that our limbic system reacts to things. We could go into the biology of it, but what we really want you to think about is that when we are emotionally dysregulated, what we're talking about is our emotions get too big for us to manage.
Right.
And just as you said a minute ago that, what's overwhelming for me may not be overwhelming to somebody else. It's the same thing with emotions that are our ability to manage different emotions. Richard, whenever we talk about this, one of the first things that comes to my mind is a young man that we saw that you and I treated, goodness, it's probably been 15 or so years ago, who, while sitting in a session with us, he asked the parents to stop at the store and buy a video game on the way home. And dad said, no, not today. And the kid completely lost it. And, storms out. We thought it was going to break the door on his way out. We finally find him out in the parking lot, like trying to rip shrubs out of the ground and like screaming, and all because he couldn't get a video game on the way home. And some would say, now, being told no, that you can't get a video game on the way home isn't that big of a rejection. But to him, it sent this kid like completely over the edge. I mean, you remember this, and it went on for like 30 minutes.
Yeah, he tried to break the windshield of his parents' car.
Yeah.
Up a limb of some type. It was trying to break the windshield in the father's car.
Right.
I mean, it was an extreme reaction.
As though that's going to convince dad to let us buy the video game on the way home.
But that's a pathological loss of control, right? I mean, that's where emotion just completely took over.
Right. And as you can imagine, those of you listening, this wasn't the only problem that this young man had. If seen today, he would be diagnosed with DMDD. And and so that rejection sensitivity dysphoria, that difficult and exaggerated response to rejection
Right.
makes sense within the confines of that diagnosis.
Right.
It
But
was
within
like
the
this was the only thing that he ever did.
that's right.
There were lots of other things going on.
Right. And as a clinician, you have to be very careful if somebody's coming in and they're talking about just rejection sensitivity, might not, but it should be within the confines of a recognized condition.
Right.
Right.
And this is one of those areas where, Dr. Google is really problematic for us as
Yeah.
as clinicians, because people, you do that quick Google search and you come up with, what are the symptoms of rejection sensitivity dysphoria? And my goodness, when you look at the list of things, it's like who doesn't have some of these things?
I think of AI, which I think most high school students today would say, yeah, we use AI for everything. We use it all the time.
Right.
I think if you typed in AI and got an AI app and typed in what are the symptoms of rejection sensitive dysphoria, it would give you an entire explanation. It would generate several paragraphs. You could take that to any clinician in the, here you are, you have a complete explanation of this generated by AI.
Yeah. Yeah.
But as clinicians and parents need to be very careful
Right.
with these newly minted diagnoses of phrase. They're not diagnoses,
Yeah.
conditions. I don't know what to call them. I don't know what to call these things. They're not diagnoses. They're sort of subtexts within a diagnosis.
Yeah.
But we need to be very careful about that because the symptoms that a person is feeling, and as with so many of these disorders, most of us, and especially teenagers, experience those symptoms at one time or another.
Absolutely. You look it up and you get things like, they tend to be strong people pleasers, or they feel more embarrassed or more self-conscious than you would expect, or they
Right.
have low self-esteem or high levels of self-doubt. I mean, when you're talking about kids, or when you're talking about teenagers, especially today in some of the climate that we're dealing with as it relates to school and so many, just the political climate and all these other things going on, there's a lot of people who, engage in negative self-talk. You know, um, these are symptoms that a lot of people experience, a lot of kids and teenagers experience. Doesn't necessarily mean that again, it takes me back to around the time we were working with that young man that I was talking about.
Mhm.
The big thing going on at that time was early onset bipolar disorder. And
Right.
we were right there with it. And we were, trying to help these kids. And we would always say, we're calling it early onset bipolar disorder, but it doesn't really feel like that. And the leading, writer, you know, dissemination of information was coming from several people. And I remember
Right.
that one book that came out, and it had like 2 or 3 pages, just a list of symptoms
Right.
associated with it. And it's like, you're looking through that list and I'm like, tell me one kid that doesn't meet this criteria.
Well, you began to give the criteria, they're people pleasers. And I'm
Yeah.
thinking, in my head, I'm thinking of a teenager sitting alone in his bedroom or her bedroom, and they discover this list and say, people pleaser, check. Self-conscious, check. Self-doubt, check. Um, sudden outbursts of anger or tears or sadness, check. Negative self-talk, check. Difficulty managing my reactions,
Right.
difficulty finding relationships to be emotionally draining. Every teenager I know of at one time or another would check every box.
Right.
Now, the danger there is they say, well, if I have all these symptoms, there must be something wrong with me.
Mm-hmm.
And therein lies the problem, is that when they begin to accept that there's something wrong with them,
Mm-hmm.
now we're headed to some pretty difficult and sometimes dark places.
Right.
Once these teenagers say, there is something wrong with me, then life starts to shrink. It starts to, so therefore I can't do this. I can't go to school. I can't get a job. I can't. And that's the problem here, is that you check off these symptoms, then you convince yourself something is wrong.
Right. Yeah, it's like so many of these things are just remind me of like horoscopes, because you read it, and no matter if you are the type of person that believes those things,
Right.
whatever you read, you immediately have the ability to associate it with yourself.
Right.
You're going to encounter someone that's going to give you some very profound news this week.
Right.
Okay.
Yep.
That is so generic, but you read it and you're immediately related to something that happened. It's like,
Right.
that happened. Oh my gosh. I think people do the same thing when they read these types of lists of things where, and they say, oh my gosh, the kid that I was talking about a minute ago, would you say that he was a people pleaser? Not in any way. That kid was
No.
not a people pleaser. Would you say that he has self-doubt? Not at all. That kid he thought he could rip these shrubs out of the ground.
Right.
I mean,
Yeah.
so do you think that he was more embarrassed as he's outside in front of everybody in the parking lot screaming and crying and trying to break his dad's windshield in his car? Not at all. But I can guarantee you that once he becomes an adult, and if he's still demonstrating those things, we haven't seen this guy in a long time, but if he could read this and he said, you know what, those things fit.
Right.
That's right. And so we have to be very careful, because we have this tendency to find some way to apply these things to us as a way of, it's almost a confirmation bias that we can say, that's right, because I must be a people pleaser, because, that's why it bothers me so much when people reject me, because I must be a people pleaser.
That's right. And we see this happening across diagnoses, adult ADHD. There's an explosion today of adult ADHD. Well, if you're an adult and you have a job and you have children and a mortgage and car payments and house payments, your brain is going to be cluttered. You're probably going to be a little bit distracted. Okay. That's completely normal. Memory loss in the elderly. We did a podcast on that a few months ago. And the same thing, if you're over 50 or 60 years old, you're going to start to experience some memory loss. It's a normal part of the aging process. It doesn't have to be pathologized. It's not, you don't have a diagnosis. You have normal life changes.
Right. And I think that the really important reason to emphasize that is that when you think about these other conditions like ADHD or even disruptive mood dysregulation disorder, because we have to think about the brain, right? And all of this is connected to the brain. One of the first things we said in today's podcast is that emotional regulation is managed by the frontal lobes, the prefrontal cortex, which helps to mediate and manage our emotional reactions to things that are happening around us. With people with ADHD, for example, we know through lots and lots and lots of research over many, many, many years that the prefrontal cortex isn't functioning at the level that we would want, based upon their developmental level and their age and things like that. And so their frontal lobe isn't managing their behaviors and their impulses and their emotions in the way that one would expect it to by their age and developmental level. So it makes sense that if the part of your brain that's responsible for regulating emotions isn't mature enough, based upon the age that you are, it makes sense that you're going to have some emotional dysregulation.
Right, exactly. And we know that ADHD is a problem of the frontal lobes. I mean, that's where it resides, somewhere in the frontal lobes, where the executive functions are. And so, yes, if you have ADHD, it's very likely that you're going to have an executive function deficit, because it's the same brain region that's it's not fully developed, or it's not performing as well as it should for whatever reason. And so these brain areas that filter and regulate the symptoms coming into our body from the outside, they aren't sort of managing that flow of information as efficiently and effectively as they should. Okay. And that's why something like rejection sensitivity is associated with ADHD, because it's the same area of the brain that regulates our emotions, that
Mhm.
regulates our behavior.
Right. And that relates the same thing with disruptive mood dysregulation disorder. You see the same thing with anxiety, with a
Mhm.
lot of the common mental health conditions that we're dealing with, that anything that it affects or influences the way in which we process that information and regulate those other brain responses to things, it makes sense that you may have some sensitivity to how you manage rejection. So
Right,
it makes sense that those things go together. It
right.
doesn't make sense that rejection sensitivity dysphoria would happen in isolation.
I think that's the important point. Don't, but people are going to come to us
Right.
and they're going to ask to be evaluated for, with the idea that they can be treated for this disorder, this dysphoria that they're experiencing.
Right.
And people will do that. They'll say, yes, I think, you really do. You do a diagnosis and say, yes, it really looks like you have it, but not in isolation.
Right.
Okay. Because the problem is, if you move from diagnosis, and you remember, you diagnose a disorder, and this really isn't the disorder, so you need to be very careful, but you move from diagnosis to treatment.
Right.
Now, and so what is the treatment for this rejection sensitive disorder? And what we're told is, well, it's the same medications that we use for ADHD, but it's used off label.
Right.
And there's a slippery slope there, but off label,
Right.
which in many ways is an advantage. In many cases, it's an advantage. You can use a drug, might be effective. It's not designed for that, but it's effective in treating that condition.
Mhm.
The medications that we would use for this dysphoria are the same medications that we use for ADHD.
Right.
Well, what are you treating? Are you
Right.
treating are you treating sensitive disorder, or are you treating ADHD?
Right. I think that that's a really important point. And yeah, so we could go in and we could talk about medications for ADHD. But as you said, if those things are effective, then probably what we're really treating is ADHD. We're not treating, RSD. If you have a situation where you or your child or someone is experiencing RSD and it appears as though it's in isolation, I think that our recommendation or our thoughts about that is very similar to what we talked about with PDA last week. And that is, we are not doing our kids and all very much justice. And I'm going to be careful how I say it. We're not doing them very much justice by letting them get away with that.
I, I agree. We have to be very careful that we don't allow our children to indulge this notion that there's something, that they have some serious mental health diagnosis.
Right. You don't have a mental health diagnosis just because you get upset when you can't buy a video game on the way home.
Right.
That's not that's the child has, again, if we're talking about, if we're saying that RSD is present in someone in complete isolation from anything else, there's no other signs of any other condition, and we're
Mhm.
only talking about the rejection sensitivity dysphoria, then we need to get into and focus on the way that the child is managed and how we're responding to the child when they have some of these symptoms.
That's right. If you think of this as a two-sided coin, on the one hand, because of social media and media in general, this notion that, oh, that explains why I do what I do.
Mhm.
I have OCD. Oh, that explains why I keep losing my keys. I have ADHD.
Right.
Oh, that explains why I'm depressed. Now that we have destigmatized mental health,
Mhm.
we've removed the stigma of many of these disorders. People are no longer embarrassed to say, "Oh, I have ADHD. I have this. I have that."
Right.
Generation or two ago, you never wanted to admit any of this stuff. Oh my God,
Right.
there's nothing wrong with me. We have destigmatized. We've taken away the stigma, And people say, "Oh, I'm so relieved to know that I have A, B, C, or D." The other side of that coin is you probably don't,
Right.
because there's an 80-20, most of us, 80, 70 or 80% of us don't have a diagnosable disorder. So chances are you don't have it. But the other thing is that you don't want to identify, you don't want to think of yourself as being depressed. You don't want that to define who you are.
Right.
That's the other side of this, that okay, maybe it helps to explain some of what you do or the way you feel, but you don't want to consider yourself mentally ill, because that moves you into the helpless. I can't do anything about it. I'm just, this is just who I am. As they say in some of nay, nay,
Right.
no, you can't define yourself. And Bernie, you and I deal with a lot of particularly older teenagers who are defining themselves by their diagnosis. Well, I have bipolar disorder, so I can't.
Right.
That's the danger.
Absolutely. And so if you're again in this situation where you or somebody you're responsible for, or somebody that you care about, is talking about, this rejection sensitivity dysphoria, and in it, again, it's in the absence of anything else, any other mental health conditions or anything else, there needs to be a discussion. I would strongly encourage you to see a therapist or a counselor who is cognizant of these things and aware of this. And usually people who are, who do parent training and work with families, usually they're going to be knowledgeable about this, and they can help work through some of these things to build the child's resilience and build their ability to manage this. We're not saying that they don't have a hyper reaction to things that happen to them. That they are hyper reactive to rejection. We're not saying that they're not. What we're saying is that it's not a disorder. We need to, for lack of a better phrase, we need to train that out of them. We need to teach them and build their resilience so that they can handle it, because there's nothing from a biological perspective that would say, again, in the absence of ADHD or something else, there's nothing else biological that would say, oh, they can't handle rejection. They can handle
That's right.
everything else in their life because they don't have any other conditions, but they just can't handle rejection. That doesn't fit. So,
Right. Nope.
all right. Well, that's it for today. We'll be back next week with a couple more podcasts. We're really enjoying this 2 podcasts a week thing. And so just gives us the opportunity to learn and talk about more things. And so if you have any thoughts about anything that you would like to hear us talk about, email us, reach out and let us know. Some of these topics that we've talked about over the last couple of weeks actually came from listeners who wrote in and asked us about them. So
Right.
if you have any thoughts or questions about things, let us know, and we are happy to put something together and talk about it. So, all right. Until
Good.
next time, stay happy, stay healthy, and forget to be afraid.